of time, extra time, because all these participants are working at several places and doing COVID duties, etc. Usually we start our session at 7:05, sir. So is that all right, sir?
Yeah, sure. But we can use that time. Can we test whether I can share screen?
You can. Yes, sir. Please. I made you the co-host. You can try sharing, sir.
So I just press the share screen.
Yes, sir.
And just guide me through. Now
yes.
What I'm.
Is your PowerPoint on the desktop,
yes,
sir?
Yes. Okay. Yes, it's on desktop. I've opened it. So I just press that.
First just click screen share, share screen.
And then share.
And no, sir. And then you have to click screen. Yeah, right.
Okay. So now
I can see your screen, sir. Yes.
Okay. So I hope you can see the screen.
Yes, sir. I can see. Yes. Perfect.
Okay. So now I go back to stop share.
Yes, sir. So if your PowerPoint is already open, and then you just have to say share screen, and then just directly click the PPT, sir, which is already open there. You can see on the screen. You need not again go back to the desktop.
Sure. Great. So we are going to wait for 5 minutes. So
3 more minutes, sir. It's 7:02 now. 3 more minutes.
No problem. Great.
So usually, so just to give you a bit of background, so this is a certificate course in pain and palliative care, which we are conducting for doctors and nurses from Sri Lanka, working in various district hospitals of northern province of Sri Lanka, sir.
Okay.
And all of them are not working in palliative care and are very new to palliative care. Early in 2018, we had 2 doctors and 2 nurses who came all the way from northern province Sri Lanka. They underwent 6 weeks of palliative care training with us in Hyderabad, and they went back and started, and they're doing a bit of home care also, sir.
Okay.
So this is through an affiliation to University of Jaffna.
Okay.
And they thought, initial meetings did happen, thinking that they'll send a couple of more doctors who will come all the way to Hyderabad and undergo this training. But unfortunately, due to this pandemic, so everything got stopped. And still, but the University of Jaffna, Dr. Suren, and Hyderabad Center for Palliative Care, we thought that we'll do this course virtually. Instead of 6 weeks, we'll make this as 6 month course. Okay. Because why we thought it will be 6 months, sir? First 3 months, it will be purely didactic. And the next 3 months, it's purely case-based presentations, case discussions, and topic presentations and assignments, sir. So initially, we have done this course twice a week, Wednesday and Saturday. But majority of the participants, because they're being pulled out of their clinical time, so most of them couldn't attend, and they preferred to have these sessions only once a week. So that's the reason, and most of them prefer to have them on Wednesday 7 to 9 rather than Saturday and Wednesday or 3 to 5, etc. So now last 3 months we have been doing these sessions only on Wednesday 7 to 9 p.m. sir. And with this week, actually we complete the theory part of it, sir.
Okay.
And we have only one more session on setting up of palliative care unit, which is going to come up next week, sir. That is on September 8th. Once that starts, it's mostly only case-based discussions, sir. And all these doctors are, the actual registered participants are about 43 to 45. But unfortunately, again, due to their busy schedule, participants are somewhere only between 20 to 22, sir.
Okay.
Not most of them. So tomorrow, after this 8th session, September 8th week session, they're going to take a stand, the committee, and decide who are going to participate in the clinicals.
So
yes, sir.
What about contact classes? That is, if they visit Hyderabad and see how things are being done in the hospice and home care as well as MNJ.
Already they are doing bit of palliative care, sir. As I said, like Dr. Suren and other doctor
Oh, in Sri Lanka.
in Sri Lanka, in Northern Province, Dr. Mathurahan, Dr.
So
Gaushigan.
they already have a
Some
facility.
kind of palliative care, sir. Yes.
Oh.
So these people are, I mean, they are planning to see like how we have to put them in their clinicals, sir. We are just still maybe after this 8th, the committee is going to review and then see how we are going to do it. Yeah, sir, I think it's 7:05 and we have to start the session. Once again, good evening, sir. Good evening to one and all. This is Vinila, Program Coordinator from Hyderabad Center for Palliative Care. So just a Zoom etiquette once again to all of you. I see most of you have renamed yourselves. So if you do not know how to rename, please type your name in the chat box. We'll rename it for you. And please turn on your video cameras. And I just want to tell you, sir, this is a very, very, very quiet group. So like when you say something, like most of our participants are, I don't know why they shy away or they think they may be wrong and they don't answer, or I don't know. All of them are very, very quiet. So earlier faculty, what they have done is like they have called on the names so that they get like 1 or 2 responses. So sorry, just to say that, because this is a very quiet group, sir. And when you have, sir is going to take the session today on palliative care emergencies. And once you have any question during the session, please raise your hand. And if you have any question, please type in the chat box. We'll read out the question for you. And the faculty is here with us and they're going to answer. And the other thing is like, please, I see still participants have not turned on their video cameras. I request all the participants to please turn on your video cameras. It will be very nice. And please tell your friends that in another 10 minutes, if they don't join the session, unfortunately, they'll not be allowed to the session. It will be very nice if they can all join within next 5 to 10 minutes. So here today, I think it's not like end of the didactic, but we have come to the close to the end of the didactic sessions for our 6 weeks, 6 months palliative care training program. And it's really, really great pleasure. And I'm very happy to introduce Dr. Biju Raghavan. So sir is like one of the very senior palliative care faculties and experts in palliative care working in southern part of India, that is Kerala. So usually Dr. Biju sir tells me that I am the student of Dr. Gayatri, but Dr. Biju sir is no more student of Dr. Gayatri, and sir is at the level of Dr. Gayatri Palat, whom you have already met. So sir is an anesthetist by profession basically, and sir is currently working as a senior consultant and heads the Department of Pain and Palliative Medicine in Rajgiri Hospital in Ernakulam, Kerala. I know this is very little bit of introduction which I have given about sir, and I hand over the session to you, sir. We want you to, we want you to tell us more about yourself, sir. Over to you, sir. Thank you so much.
Thank you, Vinila, for your kind introduction and comparing me to the Dr. Gayatri. I can never be at the level of Dr. Gayatri. She's my teacher, was my teacher, is my teacher, and will always be my teacher. It is my privilege that she also considers me as a friend, which I'm always grateful for. So, so
thank you, sir.
It's a great pleasure to interact with you, Vinila, and be part of the program from Hyderabad. It's been almost 2 years since I visited Hyderabad. So it's such a pleasure to see the great strides you people have made over there and becoming actually a model and leaders in especially pediatric palliative care, and how you can collaborate with government to create hospices in collaboration with NGOs. And marvelous job people are doing, and of course excellent academic program and research you people are doing over there. When I say you people, I consider myself as part of Hyderabad
you are, sir,
program,
you are.
because it's with pride when I say that I am a faculty for the Hyderabad program. So Pen Palliative Society Hyderabad. So I have been in the field of palliative care since 2003. So it's been some time now, and as and welcome to all the participants who are there from very far off. I hope today's session will be helpful. I did my post graduation in pain and palliative medicine in from Amrita Vishwa Vidyapeetham University, which is again in Kerala, and I've been working in this field, as I said, since 2003. I've had some experience working with NGOs, around 7, 8 years of working with NGOs, and then uh, around the same number of about the same number of years working with private corporate quaternary or tertiary centers. And my area of interest is, of course, I'm fond of teaching. So teaching is an area, and supportive, uh, onco supportive care, respiratory supportive care, end of life care, and chronic pain is an area of interest. And I'm also a communication skills trainer. So that is, I don't want to, deviate too much from today's topic. Today we are going to talk about some emergencies that we may have to deal while we are practicing as a palliative care professional. So with your permission, Vanilla, may I proceed with the presentation?
Yes, sir,
Yes.
please. Thank you, sir. That's
And
so
as
nice
Vanilla,
of you.
and as Vanilla said, if any of the participants would want to stop me midway and ask a question, raise your hand. Vanilla will arrange for that, or you can type in your query or comment or an experience either through chat, or at the end we hopefully will have a Q&A. So please feel free to engage. It is not, we are all learning together. It is, it's not that I have all the answers as well. I hope to give answers if I can to your questions. So I should be more worried than you asking questions. So with that, I'll start the screen sharing. Okay. So this is where I'm working. It's in Kerala, middle part of Kerala, called Cochin. I'm in the rural part of Cochin. The district is Ernakulam district, but mostly people are familiar with Cochin. And it's in the middle part of Kerala, actually. So nearer to Jaffna than from Hyderabad. Hyderabad is farther away. So, so how do I proceed further, Vanilla?
You just have to click next slide, sir. Your down and up arrows on your laptop or the keyboard. You can just,
Okay.
yeah. Yes, sir.
Yeah, right. Thank you. Thank you.
Okay.
So I assume that pain has been covered during the course because this is the last part. So we'll be talking about only pain in terms of an emergency, and or other topic will be spinal cord compression and SPC obstruction, and something called as a terminal bleeding. So these are the four. Of course, there can be other emergencies, but these are the four main emergencies. As a palliative care physician, we are usually called upon to deal with. And why palliative care people? Because many a times these patients would be in a fairly advanced stage of malignancy. So the treating consultants would rather we take care of it than them. But it's always a teamwork. So coming to severe pain, as for our usual pain assessment We will try to find out what is causing the pain, what kind of pain it is, whether it's a nociceptive pain or a visceral pain or a neuropathic pain, and what is causing it. Is it tumor related pain or some other non-tumor related pain? And then we should always consider whether there is any corrective measures we can do. For example, if there is a fracture, whether there is a role for surgery uh, or stabilization, spine stabilization surgery, or something like that. So these are something that we will consider, which is normal part of our pain assessment. However, coming to the main issue, that is, here you are in your clinic and somebody has been brought to you, known patient with advanced malignancy, in severe pain. You need to palliate that pain because a severe pain is always an emergency. And in this case, we have two options to control the pain fast. One is a IV morphine trial and another is a IV fentanyl trial. And IV fentanyl trial, because fentanyl is a much shorter acting opioid compared to morphine, so it is better for short procedures. So, so the indication for an IV morphine trial would be a patient who has been brought to you in severe pain, absolutely distressed patient. And so it's a small procedure. It's if you know how to do it, it's a fairly safe procedure also. So before you start the procedure, you will have to, of course, check about the pain, general assessment, etc., etc. The normal things that as a doctor you would do, pain scale and things like that. So before you proceed, you have to give pre-medication, metoclopramide. This is basically to prevent any opioid-induced nausea, vomiting. And of course, you'll have to monitor the blood pressure saturation because you know that morphine can cause vasodilation and leading to hypotension. And sometimes, if you are not careful, and we may cause desaturation. So just for this background monitoring, you do these two. Nowadays, it's very easy to have a pulse oximeter. You can get the saturation and your normal BP apparatus, sphygmomanometer, you can check the BP. Even if you don't have, fancy gadgets, you can do it in a very simple way. So our usual morphine ampule is 10 milligram in 1 ml. Earlier, when I used to be a student, it used to be 15 milligram in 1 ml. So we were taught to dilute it to 10 ml so that each ml would contain 1.5 milligram. But nowadays, the ampule that we're getting is usually 10 milligram in 1 ml. So we dilute it to 10 ml. So each ml contains 1 milligram. And if we are having a patient who's totally opioid naive, that is, they have never received morphine or fentanyl, any of the strong opioids, then better start with 1 milligram as a bolus and repeat every 10 minutes. If you are, you become experienced, you can start with 1 milligram, skip and go up to 2 milligram, etc., etc., based on how you are able to assess the picture clinically. But if you are new, then maybe you should be careful and start with 1 milligram IV bolus every 10 minutes. And every 10 minutes, you will monitor the vitals. You will ask the patient whether how is the pain. You document it every 10 minutes. And also look for any uh, opioid related neurotoxicity. The most common opioid related neurotoxicity would be drowsiness, which is the most common thing that you will come across. The other, not that common, but of course, you have to look out for it would be a myoclonus or a delirium. So why I'm saying look out for any neurotoxicity, because our idea is to give just enough to give them satisfactory pain relief. Our idea is not to take the person to 0 out of 10 pain score. The idea is that the patient says, okay, now I'm feeling better, stop the trial at that point of time. Or if the patient has pain but is showing early signs of drowsiness, then that is the point where you should stop the trial. So I'll repeat, you give a metoclopramide 10 milligram IV pre-medication, monitor the vitals, especially BP and saturation, and then give injection morphine 1 milligram IV bolus every 10 minutes and repeat it till the patient has either satisfactory pain relief or is showing early signs of drowsiness, whichever is earlier. You stop at that point in time. And just for our what you call completion sake, let us say the patient had satisfactory pain relief with total of, let's say, 10 milligram, or let's say 7 milligram or 8 milligram of morphine after giving 1 milligram every 10 minutes or 2 milligram every 10 minutes, whatever. Let's say the patient had satisfactory pain relief without any drowsiness at, let's say, 8 milligram. And then we have to convert that to oral. So we'll round it off to the nearest. So we can give 10 milligram of oral morphine every 4 hours. Okay? So first you find out what is the patient's requirement of morphine. Now, the same principle applies for a fentanyl trial, the same procedure, except that fentanyl is calculated in microgram, whereas morphine in milligram. So morphine 1 to 2 milligram every 10 minutes, fentanyl would be 10 microgram every 5 to 10 minutes. We can actually titrate every 5 minutes or 10 minutes, just like morphine. Now, the advantage with fentanyl is it is what you call the side effect profile is better than morphine, but more importantly, it is a much shorter acting opioid. So it is a better choice if you want to do some minor procedure. For example, if you want to do a cleaning and dressing for a very painful ulcer, maybe fentanyl trial would be a better option. So that was what pain was concerned. And if you have any questions, queries, comments, etc., please feel free to put it on the chat. Moving on to the next topic, which is spinal cord compression. In malignancies, up to 5% malignancies will present with the spinal cord compression, especially in the advanced stages. And the common malignancies that do present with spinal cord compression would be prostate, breast, lung, myeloma, lymphoma, and renal malignancies. And how they cause spinal cord compression, around 85% are due to metastasis, 10% would be tumor extension, and 4% intramedullary from the primary, intramedullary as the primary, and 1% would be hematogenous spread into the epidural spaces. The most common site would be thoracic spine, around 70%, followed by lumbosacral 20%, and cervical 10%. As part of my normal practice, when I do a physical examination, I make sure that I check the spine for any tenderness from top to bottom. So I tell the patient, I'm going to check your spine from your head down to your tail so that they know. So they don't feel surprised when I'm checking them thoroughly, poking them in their spine. So it's not just for spinal cord compression, in case there are any mets, any bone, it's just make it a normal habit to check the spine. Even if the patient doesn't have any symptoms, you'll be surprised. I've discovered so many spine tenderness without the patient knowing that they had a tenderness. Only while examination that they realize, oh my God, I have a pain here. They did not know, because they may be having so many pains in different parts of the body that it might get what do you call, covered up. The spine tenderness may not be recognizable to the patient. So just make it a habit to go through the spine for each and every patient, because we know the consequences of spinal cord compression and and what you call pathological fractures of the spine, devastating consequences. So it's always good to do a physical examination. And many a times I refer patient back to the oncologist, telling them, see, there is a tenderness. Why don't you check for that? And so they will be very busy with so many of their patients. So if we detect something and we forward refer the patient back to them, the oncologist will also be happy that we are detecting something and referring the patient to them. So, how do they present? Again, not surprisingly, majority of the spinal cord compression present as pain. Then another common, around 90% other common presentation would be weakness, along with pain, sensory level in 50%, and the sphincter dysfunction in 40%. But the cardinal feature would be pain would usually precede the other symptom, that the weakness and other sphincter problem and all would usually develop after the pain comes in. So whenever you say you have patients coming with pain in the back, take it seriously, do an examination, and I would say do an examination even if they don't have a pain as a complaint when they come to you, a pain in the back complaint, even if that is not there, as a matter of routine, just check the spine or for all your patients. Diagnosis straightforward. You get a history, physical examination, an X-ray, MRI would be diagnostic. So that is fairly straightforward. Then what do we do about it? Most of the time, as a palliative care physician, my role would be to start a steroid as soon as possible. Because the first thing would be to start a steroid. In my usual practice, I would be starting, depending on the severity of the symptom, either 8 milligram, 16 milligram, or 24 milligram. I usually don't go beyond that, but 8 to 24 milligram should be a reasonable, good dose as a starting point, and then make sure that the patient reaches the right place, because this is definitely an emergency with very serious consequences. So just call up the your radio diagnosis radiology department and try to get a radio diagnosis as early as possible. Just call up the radiation oncology department and tell your radiation oncology colleague that we have a potential spinal cord compression, and see that in case the person needs any radiotherapy there, just call up a neurosurgeon or a spine surgeon if you have a spine surgeon, and tell them that we have a patient over there and we are referring this patient for radio diagnosis, and probably the patient will come to you. It's important to liaise with various your co-specialities, so that the patient has a smooth uh, passage through various stages of diagnosis and management of this, because this is an emergency. And if we do it in time, you can definitely create a big impact as far as quality of life of the patient is concerned. And don't underestimate chemotherapy. Talk to your medical oncology colleagues and see whether there is a role for chemotherapy in this particular case. Maybe not as an emergency, but definitely as part of the spinal cord compression treatment protocol. So specific to us, what is our role as palliative care physician? As I said, first, push in some steroids, because we definitely need an anti-inflammatory activity locally to reduce peritumor edema, because it's not just the tumor which is going to cause destruction to the local tissues. It is also the peritumor edema which contributes to the pressure effect. So we reduce the peritumor edema with steroid, and unless there is any specific contraindication of, for example, if the patient is diabetic, very high blood sugars, or has in case a history of any allergic reactions. uh, Unlikely, but usually we push in a steroid, irrespective, because it definitely buys us some time before any specific management can be initiated. Of course, you can expect the patient to be in severe pain and you resort to your WHO ladder, or even for that matter, the emergency pain management protocols that we talked about earlier. And uh, later in the pathway, we may be involved in helping patient with bladder care, bowel and skin, in case there is some deterioration of the condition and patient needs bladder care, bowel care and skin care, and maybe continuing them through a home care program, or the calling of the local GP, or a home nurse service center to tell them what needs to be done. And also collaborating with the physiotherapist or the rehabilitation team, whether how we can, after the initial surgical intervention or radiation intervention is done, how we can retain ambulation. So whole lot of liaising work is needed. And of course, cannot talk enough about communicating with the patient, telling him or her what is going on, what is being done, what can be achieved, what cannot be achieved, talking to the family, and also talking to colleagues, and telling them what is going on. The basically the last point that I want to emphasize upon, most of the time we feel it is not our job is just our specialty, we look into what we do. It's also equally important to interact with our colleagues of other specialties, so that we all work together as a team. Like our body has arms, legs, nose, ears, everything, all different looking organs, but when we work together, we are one efficient mechanism. So it is very important that we have to liaise with various other specialties, so that the patient's pathway from diagnosis to emergency treatment to subsequent care and rehabilitation is smooth. Then another important topic would be superior vena cava obstruction. Personally, I have not come across much of this in my professional life, but it is definitely there. Causes could be like external compression, intraluminal thrombosis, or direct invasion of the vessel wall. So basically, the idea is that the superior vena cava is squeezed by any of these mechanisms. And prevalence wise, not surprising, bronchial carcinoma, around 75% of them tend to cause SVC obstruction. And other malignancies like lymphoma, breast cancer, adenomas are also known to cause SVC obstruction. Symptoms, as is to be expected, there will be breathlessness and a feeling of being choked. That word is something that patients often use, as if they say that as if somebody is holding my neck and choking me to breathlessness. It's a very terrifying experience. Along with it, there will be swelling of face, neck, trunks, and arm, and usually it is of acute onset. It develops very fast. And when you look for signs, you can see, like the picture shows, venous distension, plethora, and the speech there might be strident. So when you see again the just like span cord compression, steroid, because you want to remove the peritumor edema, relieve the distress, and radiotherapy, palliative radiation, and where possible, stenting of the SVC obstruction, palliation of other distressing symptoms, because there's sometimes usually when there is breathlessness, the patient may be in panic or in severe anxiety. We may need to calm them down. And also communication, we have to explain to the patient, and explaining also help people calm down. And we also explain that what is what are the things that we can do to take care of your problem, and of course communicating with the family also. And just like the previous issue, interdepartmental liaising is very important. Remember that any kind of emergency that we are dealing with, usually it will take a multi-specialty team to work together to get the best results. Just one specialty, one person say, okay, it's my way or the highway. That doesn't work. In emergency, we have to liaise with various, because everybody has their own skills which they can bring to the table. Now, coming to the last topic, which is bleeding. Now, bleeding is something that we do come across very often, but terminal bleeding is something that may happen rarely, but when it happens, it can be a terrifying experience. So it's very important that we anticipate it. So before that, we'll talk about a little bit of the normal bleeding that we come across in palliative care. The most common is the surface bleeding from tumors. This kind of metastatic tumors or breast malignancy, fungating tumors, uh, pelvic masses. A lot of these tumors will have surface bleeding. Usually, it will be kind of an oozing kind of a bleeding. Then the other types of bleeding like epistaxis, hemoptysis, hematemesis, meline, and the hemoptysis, epistaxis, and hematemesis are usually reported very fast, but melena is something that you have to suspect, because many a times the patients and the family may not be aware that they have melena. It is something that you have to ask if there is any change in color of the stools. And if you're suspecting because the patient is fatigued, is pallor, etc., it is always best to get a stool of blood done. Whereas if there is bleeding coming from the nose, or when there's coughing and there's blood coming, or if there is vomiting and there's blood in it, they'll definitely come running to you with these kind of symptoms. What are the common cancers at risk for bleeding? Head and neck cancers, pelvic tumors, and fungating tumors near major blood vessels. They especially are high risk for terminal bleeding episodes from leukemias. Now, surprisingly, before coming to palliative care, I was not aware of it, that radiation is an excellent way to control bleeding, especially the low level bleeding, not the like the artery punctured big spurt of bleeding, not that kind of bleeding, the oozing bleeding or the constant persistent bleeding. Uh, Radiation is very good because it coagulates the blood vessels. Excellent results with radiation, and not many referrals to radiation go because of for bleeding, but when you refer patients to the radiation oncologist, you will see that they give excellent results. The other pharmacological management you can do is, of course, our etamsulate and tranexamic acid. The dosage are the same. 500 milligram we can give IV, and for etamsulate you can give oral as well, 3 times a day. The idea is to give high doses in the beginning, and as the bleeding gets under control, then you can gradually titrate down and then stop over a period of time. But first, we have to give high doses because we want to control the bleeding faster. So, if you have hemoptysis or hematemesis, and definitely you must give pharmacological management. And then you have the surface coating agents like sucralfate. So, usually 1 gram oral PID. It comes as a tablet form. You have to really crush and powder it and take it, or you can have syrup form also. Now, for surface oozing bleeding, many a times, in case your patients can't afford to come to the hospital, they are very poor, and you may have limitations for financial or other reasons. Then you can actually, if you have access to sucralfate tablets, you can crush it, powder it, and apply it over the oozing wound. There also, it will cause control of bleeding because it coats the surface area. Uh, Recently, we did not have access to sucralfate tablet and for oozing wounds, and we did not want to put syrup sucralfate over the external wound because it is sweet. It may attract ants and other things. So we were not sure what to do, and the patient was very poor. Really did not have any resources to access hospital and such things. So we thought, why not? We just took a Tamsulit tablet and powdered it and applied it. Surprisingly, it gave good results, but there is no literature on it. So it is just you have to just take it as an anecdotal evidence. There is no real good information on that. So I'm just letting you know that we ourselves have had experience of difficulty in sourcing sucralfate tablets. So because we were desperate, we tried something desperate, which was the ethamsulate tablet powder and all. So it is just anecdotal. That is, we saw there was some result. Then we can have, in case your patient can have access to hospital, interventional radiology can be involved for minimally invasive procedures to control bleeding, or sometimes your surgeon may be called in to see whether something can be done about it. But there was this experience of a patient who had a pelvic tumor and had a major bleed, and the surgeon went and desperate issue went and ligated the femoral artery, ended up causing gangrene to the lower limb, and the patient would have died uh, peacefully with the severe bleeding from the you know the terminal bleeding. Instead of that, this gangrene, the patient lived on for a couple of weeks and suffered a lot. So we have to understand that where we should go for aggressive intervention and where we should not. That is something that we have to always keep in mind, that aggressive intervention to control bleeding may not be appropriate in all kind of situations, especially when we are dealing with an advanced malignancy. So that brings us to bleeding as a terminal event. So, as an example, there was this patient who had a head and neck malignancy, and the carotids were involved, and we had a conversation with the family. The family said that initially said that if there's a bleeding, that we would want him to be in the hospital and everything done, and we had a series of communication sessions with them, and it took some effort to make them understand the futility of dealing with the terminal bleeding event, right? And what was important was to keep the patient comfortable for the time that the patient would be alive in case there is a terminal bleed. So what I am trying to emphasize over here is we have to anticipate, as clinicians, we have to anticipate the possibility of a terminal event, bleeding as a terminal event, and then we have to initiate communication sessions with the patient and the family. Sometimes the family will not allow us, they will engage in collusion and will not allow us to speak to the patient on these matters. But definitely, we must initiate communication sessions with the family at least on this is what we expect may happen. We are not saying it will happen, we say it may happen. And if it were to happen, how are we going to plan for it? And the planning is very important because when it happens, it can be such a terrifying spectacle that at that point of time, it will not be possible to have a counseling session. It will be sheer panic. It's very important to make the family understand and prepare the family to do what is to be done. So, as part of plan, it is good if we can understand what would be the patient's wish if there is a possibility of bleeding as a terminal event. That is, the patient will die of bleeding. So, what would be the patient's wish? Would the patient want to be at home? Would the patient want to be taken to the hospital? What would the patient want? Where should be the place of care? Hospices in India are very few. Telangana, thanks to the Hyderabad Hospice and Palliative Care program, is developing more and more hospices. Pain and Palliative Care Society in Hyderabad is doing a great job. But even then, compared to the population that needs hospice care, the availability of hospice is very, very low. Hospice is basically a place where you provide excellent end of life care. So you need to have trained people, human resources, and other ecosystem for that. But that is very rare in our country even now. Discuss, 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 and whatever you discuss, you document it. Because discussion and documentation is both are equally important. And then whatever the care plan we have come to as agreed between all the concerned parties, we will be uh, keeping the patient, the family, and sometimes the local general practitioner or the local doctor, the family doctor, or the local hospital uh, doctor, etc., and the home care team or a home nurse, etc. Will keep everybody informed so that everybody is on the same page. And most of the time, it is a palliative care doctor who has to do this liaising work because nobody else will do it. It's important to do the liaising work. So, what happens if we are dealing with bleeding as a terminal event at home? So, of course, the previous thing that I talked about, uh, anticipate, communicate, plan, and at home, suppose it happens. So, the most important thing is to prevent emotional trauma to the patient because when a patient sees himself or herself bleeding to death, it can be very, very traumatic. So we train the family members to give a benzodiazepine to sedate the patient. So the simplest thing that you can do is give lorazepam, which you can give sublingual. We can give 1 milligram and maybe even more if needed. Because usually when a terminal bleeding happens, the patient usually does not survive for more than a few minutes. So that few minutes is very, very terrifying for the patient. So the moment major bleeding happens, whether the patient survives it or not, or sometimes the patient survives, but it's very important to sedate the patient. So at home, you always make sure that the family has a stock of a benzodiazepine. Easy to use is the lorazepam sublingually because it acts very fast. Within in a short duration, starts acting. Keep a good supply of dark colored clothes. This is the most important thing, and this should not be used for any other purpose. It has to be kept somewhere near the patient's bed, in an almari or a box or any place which you can easily access. And what is the purpose of this dark colored clues? It is to hide the red color of the blood. This is important because when you see the red blood coming out, that is what causes a lot of emotional trauma. So when you hide this, you apply this dark colored cloth over the wound, and suppose a lot of blood has come on the bed and the floor. So you cover all of these spots with the dark colored clothes so that whoever is seeing it, the patient or other family members, so whoever is seeing it, they are traumatized less. Of course, they know it is blood, but they don't see the red color of the blood. So the trauma, mental trauma is less. And teach the family members how to use the sedative and the dark colored clothes. And if possible, you can also do kind of a trial run, with not really with actual benzodiazepine or dark colored dose. You may not need to have the patient as part of the trial run, but just some kind of a trial run for the patient, for the family members to know, because they should know where the medicine is kept, where the dark colored cloth is kept, so that at that point of time there will not be confusion. Along with it, always provide some emergency contact number of your hospital or the ambulance service, something in case they want to shift the patient to the hospital in a hurry. There is some number that they can have access to. What if this happens under your care while the patient is in the hospital? Again, the concept is the same. It is to prevent emotional trauma to the patient and to the family as possible. You sedate the patient. In the hospital, you have access to uh, better benzodiazepines like midazolam, which is shorter acting but faster acting, and you can give zero point 0.5 milligram IV bolus or 1 milligram IV bolus, and you can repeat it. And sometimes in case survival is longer, or the patient is surviving for a long time, or maybe on the path of recovery, you can even consider giving uh, it as a continuous IV infusion, maintaining the sedation, because you don't, otherwise you will have to keep on giving boluses very frequently. So because if the patient is very anxious, the sedation may not last very long. And in hospital, we always have enough supply of green sheets. Most hospitals will have green sheets and green what do you call OT scrubs and things like that. They're very good in camouflaging the red color of the blood. And just like you would teach the family members on how to anticipate and what to do in case we are dealing with bleeding as a terminal event in the hospital, you should teach the nurses, junior doctors, and other people within the ecosystem who are caring for the patient, because you never know who might be on the spot when an event like this happens. Now, an event like this may not happen. In my personal experience, I've had occasions of around 2 or 3 times only in this many years. But when it happens, if I'm grateful to my teachers who taught me and prepared me. But if you are not prepared for it, it can be a very, very terrifying and traumatic experience, and even as a professional. So it is good to train your colleagues and your uh, colleagues, nurses, paramedical staff, whoever is there in the ecosystem caring for the patient. So that in case you are not there, they are there on the spot when something like this happens, they know what to do. So the concluding part of bleeding as a terminal event is patients usually deteriorate rapidly. Usually within minutes, they become unconscious, and subsequently they may die. While they are conscious, we should have the skill to remain calm talk to the patient while we are giving them sedation, so that once the sedation takes effect, then we can then focus on other things. But while the patient is conscious and scared, we have to, especially remain calm and talk to the patient in a calm manner. So if we are also scared, we are also shouting instructions, do this, run this, who is where's the nurse, this, if we are behaving that way, we are only going to traumatize the patient more. So we have to practice how we are going to deal with this by remaining calm and talk to the patient in a calm manner, reassuring them, soothing them, while you're giving instructions to the nurse, get midazolam 1 milligram, IV bolus, stat. And those things should be ready nearby, without them having to run to a far off place to fetch it. And where appropriate, put the patient in recovery position in case there's a high risk of aspiration and all. So you want to prevent that, even if they are dying of bleeding acetylcholine. Where appropriate, do that. So I am sorry I'm taking so much of time. Last two slides. So when we come to palliative care emergencies, first focus whether the problem is reversible. If it is possible, then get people who has experience, who have knowledge, experience, and expertise to help reverse the condition. Along with assessing the problem, whether it's reversible or not reversible, we also have to keep in account what is the disease status of this particular patient, whether it is an treatable condition or controllable condition or end stage malignancy. So that will tell you what the prognosis is, and also take into account what is the patient's general health. Whether the patient is in advanced cachexia, or the patient is fairly healthy, with able to function, in what condition the patient is when the patient is brought in with an emergency. Also, we have to keep in mind the, the cost benefit ratio, whether whatever treatment we are doing, whether that is worthwhile or it is going to add to the burden of the patient and the family. Whether, in whether we are in our effort to treat it, whether we are actually worsening the symptom or worsening the patient's quality of life. And also, what is the wish of the patient and family. Essentially, these are the basic ethical principles of autonomy, beneficence, non-maleficence, and justice. Justification of the resources we use. So, basic ethical principles needs to be considered when we are going to decide how we are going to deal with the palliative care emergency. And I can't emphasize enough on communicate and document whatever you're communicating, clarity in setting the goals of care. And nowadays we are talking about advanced care planning. That is, even if you are not expecting any crisis, it is always good, especially if you are healthy. Now is the good time to plan for in case you have a disease. If you are going to have an acute disease, what should be, how you want to be treated. In case you have a chronic disease, how you want to be treated. In case you are terminally ill with some kind of a incurable, progressive, advanced medical condition, how you would want to be treated. All of this advanced care planning is it's now time for us to bring into our consideration and bring into the consciousness of the society. Crisis care plan and palliative care physician, we are usually not focusing on dealing with crisis, but it is important that we sometimes have to deal with palliative care emergency. It's always good to have a crisis care plan within your department, and whatever decision you're taking, if it is within the parameters of ethics, if whatever decision you are taking, if it is ethical, then you are most probably right in taking the decision. So with that, I will come to the conclusion, and I'll be happy to answer your questions. We started a little late, so I hope Vanilla will give me some time for any Q&A that the participants would want to engage in. If you have any queries already in the chat box, Vanilla, could you, in case you have any questions, or in case you want to ask a question directly, Vanilla will help you with that. Or if you have an experience to share, I'll be very happy and interested to know that. So, Vanilla, can I stop sharing?
Yes, sir. You can stop share. And I haven't seen any questions in the chat box, but I request all the participants, we can still take 5 more minutes time, sir. If they have any questions, please either you can just speak out, unmute yourself and then ask the question, or else you can just type your question in the chat box and I'll read it out for the faculty. Any questions from any of the doctors, any of the nurses? Please feel free to ask questions. So as I said, like the very, very quiet group, sir. I don't know. So I request like all the doctors, anyone would like to share your experience as Dr. Piju sir has asked, or you have any comment? Or
Oh, I would be interested to know if any of you have had any experience with dealing with any of these emergencies we talked about, dealing with severe pain, patient being brought in howling in sheer pain, or somebody with spinal cord compression or SVC obstruction, or for that matter, severe bleeding. And if you have experience, what, how you dealt with it.
anyone would like to share? Ms. Robin or Dr. Shobika, Nilakshan, anyone?
Not necessarily because of any cancer. If you have dealt with, let's say, severe bleeding for maybe a road traffic accident or anything, but before the what you call the disease specific or the uh, let's say surgical intervention before that, when if they were brought in case you have any experience of being the first line person to deal with it, if any such experience. Why I say that, because when I was resident intern soon after finishing my MBBS, we get posted into various specialty. While I was in the casualty posting, that was for 1 month, and we used to often get patients with severe bleeding, and many a times I have felt helpless because there's such severe trauma bleeding, and it's very terrifying. Even though we are used to seeing blood and things like that, but when they are brought in severe bleeding because of accidents and things like that, of course, as a junior doctor, as a resident, I don't have responsibilities, but imagining that if I am alone to deal with it, how I'm going to deal with it, that was quite a scary experience till other people come and so. Especially there was one patient who had severe esophageal varicose bleed, and she was vomiting blood. It was hematemesis, and almost 1/4 of a bucket she vomited, and I thought she was going to die. And somehow that what was that? Some sense taken tube was used. I saw that tube for the first time in my life. So they put it and inflated it and caused because of the pressure of the balloon, they caused the varicose bleed to stop temporarily, and then they shifted the patient to the theater and did the surgical intervention. So even that kind of experiences was a learning experience. So I was wondering whether you have any similar stories to share. It's okay. If you don't have anything, that's okay, fine, no problem. But if it is there something of interest, yeah.
Sorry, there is one question in the chat, sir, asking what is the alternative drug for morphine if the patient has renal problem?
Yeah, the problem with renal problem is that morphine is not contraindicated in renal problem. Only thing is, and especially it is not contraindicated in doing a IV morphine trial. Because the problem with renal impairment is that uh, how the morphine will be eliminated from your body will slow down. So when we are dealing with regular opioid consumption, for example, if we are giving morphine for pain, let us say 10 milligram every 4 hours for a normal person, for somebody with a renal impairment, the fourth hourly may cause what you call toxicity building up, because the elimination will not be happening as fast, and as a result you may end up with uh, opioid induced neurotoxicity. So for those kind of patients, once we do an IV morphine trial to find out how much morphine is required, then we tell them you take it SOS. That is, whenever the pain starts, you take it. So instead of fourth hourly, they may be taking it, let's say, eighth hourly or sixth hourly, depending on how fast the renal clearance is happening. I can share with you one experience. We had a patient with total renal shutdown on dialysis, and who was brought to us with severe pain, and we did an IV morphine trial, and the patient had satisfactory pain relief with 10 milligram of morphine. And because there was total renal shutdown till the next dialysis, that was he was having every third day. So from getting that 10 mg milligram of morphine inside his body because of the trial, till the next dialysis, we did not have to supplement furthermore. So he was totally pain free, active, no problem. But the moment he underwent dialysis, because the morphine was eliminated from his blood, he suddenly developed severe pain. And then we gave him a tablet of morphine, and within 1 hour, he was pain free. A tablet of morphine, 10 mg tablet of morphine. And he did not need further tablets of morphine till the next dialysis. So he was getting one tablet of 10 milligram morphine after every dialysis. That is once in 3 days. Usually, if 10 milligram after trial, you have to supplement it every 10 milligram of morphine tablet every 4 hours for people with normal renal clearance. So I hope that answers your question. In case you need to switch opioid, and if you depend on what you have, uh, you can switch to fentanyl uh, or methadone. I don't have any experience with methadone, but methadone is also a good opioid to switch. It comes as a syrup.
Yeah. Any other questions? Any other questions? Biju sir, are you there? Biju sir? did we lose you? Yeah, I think sir lost his connection. So yeah, we have here today Dr. Gayatri and Dr. Suren joining us the session. Your next faculty is Dr. Gayatri. So sir, would you like to comment or share anything about this session so that we can wind up and move on to our next session?
Yeah, I think that it was a very important session and was done in the questions. But unfortunately, we lost him. So
Yeah. So sorry, I think the faculty's laptop just got shut off, and sir asked me to convey his apologize for all of you. If you do not have any questions, I think we'll move on to our next session. So today, for our second session, we have here one of our senior faculties and whom you have already met, Dr. Gayatri Pallat, who is head of the Department of Pain and Palliative Medicine at MNJ Cancer Hospital, and the managing trustee and the course director for Hyderabad Center for Palliative Care. So good evening once again, and over to you, ma'am.
Good evening to all of you, and thank you, Vinila. And hello, Dr. Suren. We are.
hello, good evening. Right.
So that was a great session, I think, but we lost him towards the end. Anyway, if you have more questions, you can always write back to us. So we are coming to almost to the end of what we decided, that initial few theory classes, more of didactic discussion which we had planned, and we are this may be one of the last sessions which I think Vinila, before next session is all about setting up of palliative care, which your senior faculty Dr. Suren and will be doing, supported by a few of us. Today what I'm going to do is talk of something about dying well, taking care of dying patients. Just a kind of overview. I'm not going into the detail of how we're going to do it. Maybe that we'll discuss again, because next we are going to discuss in the later part of my discussion. Dr. Jonathan is also going to join, and we are going to discuss with you as to how we're going to take it forward, the later part of the course, how we're going to do it. So in that will come in more details. So today I'll just give you an overview about dying well. So that is the title of my presentation. Vinila, if you allow me, I'll just share the slide from my side.
Yes, ma'am. You are already the co-host, ma'am. You can share, ma'am.
Thank you.
Yeah.
Can you see my slides, Vinila?
Yes, ma'am. We can see.
Yeah. Thank you. So I always like to share some real experience to link with what we are what we discuss always. So again, I'm taking an example of a patient which I saw in one of the patients which I saw, and I'm sure you'll relate to this patient very well. This is a story of a 68-year-old gentleman, advanced cancer lung. Patient is elderly and he has advanced cancer lung. Now, he was brought to the hospital with a history of severe breathlessness. Because he was so breathless, the physician decided to shift him to the ICU, intensive care unit. Because he was very restless, they decided even to physically restrain him, because he was just not lying down in the bed. So the arterial saturation began to fall, and the resident decided to put him on artificial ventilation. 2 days later, he died. So here, this is a story of a 68-year-old advanced cancer lung in ICU, confused, breathless, He was put on ventilator and then he died. Do you see any problem the way he died? Can you think of the way that think about this gentleman, advanced cancer lung, extremely breathless, delirious, and then he dies. Dr. Biju has joined. I just wanted to say, Dr. Biju, hello, Dr. Biju.
Yes,
Hello?
ma'am, sir is back.
Yeah. So, Dr. Biju, hello, can you hear me?
Biju sir, can you hear us? We see you have joined.
Yes.
Yeah,
I'm,
yeah.
I'm
Okay.
so sorry that I suddenly blanked out. Great to see you, Dr. Gayatri.
Thank you. So we said sorry on your behalf, and I thought I'll start my session. I hope it's all right. Do you have any closing remark which you want to make, Dr. Biju?
No. Please. Already it is 8:15, 16 going on. Please carry on. Thank you.
Thank you. And Dr. Dr. Biju, thank you very much. As always, great presentation, and you're a great teacher. I always say that. Thank you. Thank you very much. Yeah. So coming back to our patient, here we have the 68-year-old gentleman with advanced cancer lung admitted in ICU. So I want to hear from do you think it was a nice way to die? Was there anything not all right, so great about what he died, how he died? Any thoughts? You can put it, I want to see some chat discussions happening here.
Requesting everyone to put your responses in the chat box if you are
You think
not
the
able
way he
to.
died was this a nice way to die? Yes or no? I see that you're still thinking about it. From what when I thought about it, when I thought about a patient like this with such advanced cancer, elderly, and then he's dying, my thought would be, sorry, was his symptoms managed well? Now we have had enough of discussion about the pain and delirium and also dyspnea. So I also see Dr. Kandeepan's response. No, he felt that this is not the way to die. Maybe something is not all right the way he died. So do you want to comment further as to what you thought was not so good about the way he died?
You can just unmute and speak, sir.
Okay, I'll wait
Yes.
for your chat response.
Yes.
Sorry if you can't speak.
Yes.
Yes.
I think we can manage it outside without putting him into ICU. That ICU bed, give that ICU bed to the another person, another patient. It's better than giving this patient. We can treat it in outside without
Absolutely.
ICU.
I totally agree. Could we have managed the same? He was breathless. He was delirious. Maybe we could have just managed the same management. We could have done outside, not necessarily putting him on ICU. So the symptom management was not addressed, and that's the reason he landed up in ICU with all this further escalation of care. And we could have saved that ICU bed for someone who really needed it. On most hospitals, we have limited ICU beds. Even in COVID, you're seeing the same situation. People who think you can salvage, they need ICU bed, and where you already know that, okay, this patient is not going to come around, not going to get all right. If you put that patient on ICU bed, then you're unnecessarily, this is not a fair distribution of resources. So we often face this dilemma. So obviously this gentleman, I thought his symptoms were not managed well. Think about the way he died. From a medical point of view, you felt that ICU bed symptoms, and you spoke about that. But also, how about his dying as such? Finally, when he died, did he die a good death? He died all alone. His family member was waiting outside. He just could not even see for one last time, meet his family member, say goodbye, because he was all without all the tubes, sedation. He was just totally knocked out. I'm sure he just couldn't even see his family member for one last time. There was no preparation. We don't know what he wanted. Did we even ask him what he wanted? What is the kind of care he wanted? What is that he wanted to be done on his body? No way. Undignified, all the tubes going down, all possible orifices in his body, tubes going down, and half naked, secretions coming out. So often what we have seen in ICU, that often the symptom management and the care, nursing care is not often adequate as we hope for. How about this? The rationale for mechanical ventilation in advanced cancer, is it really indicated? Is it justified? Because there are several studies which have shown that when the lungs are badly damaged, there's no rationale for mechanical ventilation. Even in advanced COVID, they say ventilation has no role to play. It's not going to address the basic core problem that is dyspnea. And dyspnea cannot be managed always with ventilation. So again, there's a rationale for mechanical ventilation. And how about his psychosocial and spiritual needs? Did we address to that at any point of time? What were his emotional status? What was his social issues which he was facing? Financial, and how about his spiritual need before he was dying? Did we even think about that? What about his family waiting outside anxiously, not knowing what's happening inside? They just hear some bits of information the nurse brings out saying that he's not doing well today, or doctor saying that not well. So, but not really getting the full information and getting more anxious and becoming more restless outside. Sometimes that often leads to conflict, and they get very angry also with healthcare providers when death finally happens. So these are the problems which obviously, and if all these reasons, I don't think this patient had a good death. How are people dying today? Let's see that. Not with long time back, in our culture, death was seen as a very natural part of life, just as birth. You're born, you're dying. Which, if you look at from a religious point of view, it was considered a very natural sequence of event. It was expected, accepted, and filled with rituals. There were no surprises, no denial, no panic. That is how it used to be. When the time came, the patients were kept clean, comfortable until they drew their last breath. This is how it was some time ago. What is happening today? I'm sure you must be seeing this all the time in your life, how patients are dying in ICU. Today, even though we say India, I talk about India. India is a poor country, we say. The people are, how people are dying. We say India is a poor country with very poor resources, but still today, majority of patients, they die in ICU. The moment they become more sick, the protocol is shift to ICU, they connect it to machines and they die. And if they can't afford it, they're discharged against medical advice. They say they're left against medical advice. And most probably they die on the way home. Horrible way to die. Both ways, it's horrible to die, I think. This was a very nice article which came in one of our leading national dailies, saying goodbye with dignity, where they wrote, in India, the poor die in agony in neglect, the middle class die in agony in ignorance, and the rich die in agony on a ventilator. No one gets a dignified and pain-free death. What has happened is, with all the advancement in technology, too much of medicalization of the whole process of taking care of patients, too much of being very mechanical, we've gone to what we call it as death-defying culture, extending life at any cost. We have the slogans like beat the death, cheat death, conquer cancer. And this also shapes our expectation that when a patient walks to a hospital, he sees that word, we conquer cancer. So they come with that expectation that you have to save my life at all costs. And somehow we also get into that trap. Society has this thirst has thrust this messy and insoluble aspect of life, the old age and death, onto medical professionals. They're expecting to fix this problem, old age and death. They say doctors can prescribe good death, and hospitals are also criticized if they fail to do that. If the patient dies, the public get very angry because they expect the hospital and the doctors to fix the problem. And somewhere we also start believing that, and we start thinking that we can control death. Now, like this, education in death and dying. All of us, as a doctors, as a nurses, we face death and dying every day in our ward, whether you're doing palliative care or not, irrespective of wherever you are working in medical system, health system. I think all of us, we face death and dying. How much are we taught about dealing with death and dying in our curriculum as a nurse, as a doctor, whether you are doing post-graduation or undergraduate training program? Now, this is a study from US Medical School. They say that average total instruction on death and dying for would-be doctors is mere 17 hours in 4 years curriculum. And I don't think in India even we have that many hours, hardly any hours on anything about death and dying in Indian curriculum. I don't know how it is in Sri Lanka. I'll be very curious to know. It will be nice if you can put down in the chat, or later on if you can bring up this issue. How much are you taught about how to take care of dying?
That is actually less than that. Now only then they are planning, and now we started to teach palliative care. Now that fourth year and final year, and last week only the cancer control program, they had the meeting, and then really they are streamlining and to include all these aspects in the undergraduate medical curriculum. So we may be getting better thing to implement that.
Wonderful. That's so great to know that at least you have such unified way to kind of implement it across, roll it out across the country. We don't have anything such that. Still we are struggling, and so it's very patchy. Some states, some hospitals, they're trying to roll out such things. Otherwise, nothing is happening. So all these doctors and nurses passing out today, even they don't know how to deal with time, and we're all taught how to fix the problem. We never taught what to do if we can't fix the problem. So this again boils down to this very core issue. Is there anything called good death? Can death be good? I just want to hear from you. Do you think that death can be good? I know death, always when you say death, we say in Malayalam, we say Maranam. I don't know what you say in Tamil, that is equivalent word. When we say Maranam or death, somehow it creates very negative feeling.
In Tamil also we use Maranam. Yeah, even death notice we put is Marana Arivitha.
Yes. Yeah. So when we use that word, it comes with a lot of negative connotation, lot of fear, and death always is a very negative thing, considered as a negative thing. But can we think of death as a positive thing? Death can be positively happen to someone?
Yes, it could be, but
yes, what is your idea? Your way of looking at death being positive?
yeah, when patient is suffering from pain and everything, so it's better to, end the life rather than living with the suffering.
So when there's so much of suffering, rather end of that suffering is ending the life. How about that phase before that? Suppose you take care of suffering also. Can you think of, do you think that process of dying will be much more better than otherwise? Suppose patient is suffering and patient is dying. Okay, yeah. Death will bring end to the whole suffering. But before that also there's a period when he suffers. If you take away suffering, do you think then the whole process of dying is better?
I can't comment on that.
Suppose you take away the pain. So when you, okay, let me put it this way. When you think about your own death, what is the biggest fear you have?
Yeah, without any pain, no, without any suffering, I should.
Pain. You fear about suffering. You fear about pain, right? Suppose you have a team, wonderful team with you, who says, I'll take care of your suffering, I'll take care of your pain. You're much more relaxed, isn't it? You're much more scared.
But death is, that's the end for the life. So we know we have to, that's the end. So I don't think that
Yeah,
by
death is the end. What I'm saying is, death is the end. But what is that one thing which, when you think about death, what is your fear?
fear
Are you-
is my family and everything.
Your
So
family?
yeah,
Okay.
if I am completed, if I am satisfied that I have done to the family and they will be doing well in future, I think as a person, this is my personal idea. Suggestion. So I think I will be peace. I will be happy to die.
Absolutely. So that is your personal idea that if for you dying well means when you fulfilled all your responsibilities and the family is well taken care of and I'm sorry. My family is well taken care of, you feel peaceful and you think you can die better. That's a nicer way to die. Yeah, that is your way of looking at it. So different people may have different way of looking at it. So when I often do this exercise with my group here, often ask a group of doctors and nurses, what is your idea of good death? So different people come up with different way to see that how they see as a good death. So yes, it is very personalized thing. So generally,
Sorry,
yes,
Dr. Vithuran says his fear is like what will happen to his family.
exactly. So your fear is also about your family. Who will take care of my family if I die? So that is if that is taken care of, you think you can die well. That is your idea of dying well. So absolutely, absolutely. So if you look at good death from poets, professors, priests, they have opinion about what makes a death good. We all have our opinion about it. Bollywood in India, we live in movies, we live with movies. A day and night we breathe movies, we think movie, talk movies. It is heavily influenced by what we see in movies, the suffering which we see in movies. So when I ask my patients, children with cancer, when I say cancer, they say, I'm scared. What are you scared of? I've seen in movies that this is what happens. So it's heavily influenced by Bollywood. But then also, this is also we see our heroes dying. So my colleague says, in this movie, we having this Hindi movie, very famous Shah Rukh Khan movie, where he's having very terminal condition. But look at him. He's so well dressed, neat, no grown beard, nice hair, clean body, clean shirt, clean linen, and his girlfriend is with him, and he's singing song and he's dying. That's the ultimate way of dying, I think, which Bollywood creates. But what I'm saying is, we have fantasies about how we all want to die. But generally, when patients or you or for me, when I think about it, death, it's diverse, but we have, these are the common themes which comes up about good death. Dying in my sleep. I don't want to die. I know when I'm dying. Just dying quietly. Dying without pain. Just I want to die suddenly. Often the theme is quick, painless, and peaceful. But unfortunately, this doesn't happen most of the time. They say 10% of death happens quickly, suddenly. 90% of us, most of us today in this forum, we have around more than 25 people who have joined there. We are all going to live with some kind of chronic condition, live for a period of time, and then we die. So if that is the case, how would you like to die? That's a question we can ask. But then that death is not a surprise. We know that, okay, I have this problem, I'm going to live with this problem, and then I die. Sorry. Now, there is also very medical definition about end of a good death. They say a good death is when being treated as an individual with dignity and respect. Even in end of life, you're treated with dignity and respect. How your body is treated, how you're treated, without being in pain and other symptoms. Being in familiar surroundings, being in company of close friends or family. So this is their way of looking at national NHS definition of good death. Place of death. Setting in which patient receives end-of-life care strongly influences the extent to which goals of dying well can be achieved. The studies have shown that most people, when you ask this, where do you want to die? Ask yourself. To you, I'm not saying a patient. Ask yourself, where do you want to die? most of us, we want to die in home. And studies have shown that when you die at home, there's a greater family satisfaction, better patient outcome, higher quality of death, and lower overall financial and caregivers burden. So place of death also influences how people perceive as death. Now, death, culture, and faith, strong influence of how we perceive death. It's strongly influenced by our faith, religion, and culture, how we cope with all these things. And sometimes it can even interfere with these practice can interfere with the good death. Suppose we have seen many patients, they're suffering and they say, no, we'll take this patient to one dargah. There's somebody who will do some healing, and he'll die. He will be better. He will die. He will be all right. He will not suffer. And that process, they take the patient all the way to that some dargah. They deny him of good palliative care, and the patient die in suffering. So sometimes faith, religion helps us. Sometimes it may even interfere with good death. I see Dr. Viju Raghavan's response. I want to die in comfort with peace of mind and my dignity intact, preferably at home. So clearly, he has very clearly defined like how his concept, like how he wants to die. I know that late in the evening today, you must be thinking what I'm discussing today, why such a negative thought. I know this whole discussion brings a lot of negative feeling amongst us, but it's important that we talk about it, because as I said, most of us will have enough time if we have the choice to plan for this. Because like I said, we are all going to live with some kind of chronic condition and then die. So we have the choice to make, if we have the choice. And I also see Dr. Viduran making a comment. Most of the family members feel comfort when the members die in hospital, thinking as they did as much as they can. Because they're told like that. They think that this aura is created around ICU, that when you take care of the patient in ICU, that is the best way to die. That is how we created that aura. When you tell them the exact fact, when you tell them with honesty, what is that we're going to achieve, and give that choice, I'm telling you, most patients and the family say, if that is the case, let me take back my patient home, because my father always wanted to be in the home. And it has nothing to do with money. It is just that a choice they make. And that choice is never given to them, because we never tell them, that we never get the time to tell them. Often death comes as a surprise for all of us for some reason, and which is not good actually. I just want to give an example of this, how in olden days people used to die, and even today this is happening. I had visited this very famous temple in Nepal, a country where we have this very famous temple called Pashupatinath temple. You'll be surprised that this is a very famous sacred place for Hindu religion, very ancient temple. And by the side of the temple behind, there is a place where all the sick people or old people, they come and stay. When at home, they realize that they're dying. When they know that, okay, this is my time is coming to near to, don't have much time left for me. They say, okay, I want to go there. I want to go to Pashupatinath temple and live there. So all the sick people voluntarily, knowing that they don't have a lot of time left, they come and they live in that that place. It's a kind of olden hospice, olden type hospice, where they come and stay. And when they're really, really sick, if you see on the top is the temple, and below you see some door kind of thing. Now this is a place where very sick people are moved, and the sick people stay there. And when when they die, the body is taken out and they cremated by this river side. This river is a very sacred river. They cremated, and finally the ash is thrown into the river. Now these things, it's not done under force, it's done. The patient and the people who are the person, voluntarily they choose to do this, because that's what they believe, and that gives them peace. And this is by choice, provided they know this is what is going to this is happening to them. They know that they don't have a lot of time left. So not always that they want ICU. If you give them the choice, they may choose differently. So this is a different way of looking at good death. So when you're managing patients who are dying, so when you're dealing with patients who are dying, what is the best we can do? Remember that death is not a surprise. Only very few deaths comes as a surprise. Myocardial infarction, road traffic accident, or suppose COVID, maybe COVID, not long COVID, acute COVID, it's sudden death. Otherwise, most of us, we have long, prolonged illness. We live for a period of time, considerable suffering, and then we die. So when we know the patient is dying, how do we help them? They say, like, we can just follow some of these steps, and I think we can help those patients better. First is identifying that a patient is dying. That is very important. Impossible assessment of symptoms and the psychological and spiritual needs. First, you make the assessment and prompt management of symptoms. And Dr. Biju was speaking in his previous session about how when the patient is having active bleed, we know that the patient may die soon. How do we help that patient? So he says not only manage the symptoms, but also that is the time we start communicating with the patient and the family, understand their wishes, and finally make a shared decision making. Because if you don't do, say, shared decision making and you make your own decisions, often that leads to conflict because family is not prepared. Patient wish was something different, and you do something totally different. So that leads to conflict. Whereas if you do make a shared decision making, often it is much more in line with what patient and family wish for, and they will be together with you in this whole decision in the care plan. And of course, we have to make a crisis plan because death, when the patient are dying, often there will be some crisis. Like Dr. Biju described some of those crises: massive bleed, severe pain, severe dyspnea. Advanced cancer lung patient developing severe dyspnea is not a surprise to me. I know that this patient will develop severe dyspnea. So how do I make an anticipatory plan for him? And again, with the proper communication with the patient and the family, make a kind of a crisis plan based on that symptom. I stop here. What I'll do is, I'll play a small video. Vinila is going to help me to make play that small video. We'll watch that video and then come back with few essential point which we can pick from that video to discuss.
Sure. Thank you, ma'am. Hi, Shweta. Are you here?
Yes, ma'am. Yes, ma'am.
Yeah. Could you please share the video and the link?
Okay, sure, ma'am. Sure.
Thank you. After few seconds, like the volume starts, don't worry. Once the actual conversation begins.
Shalini, Shalini, how are you? You do look very tired.
Tired, doctor. Breathing more difficult now. Getting scared now.
Shalini, you are scared about
Something happening. My daughter got married and she's going to have a baby
I see.
after 4 months.
Okay.
Would I be able to see the baby, doctor?
That thought has been worrying you a lot. It hurts me to hurt you like this. But I really think it may not be possible.
How long do you have?
I'm not quite sure, But it does look to me that you are nearing the end of the road. It could be days, but it could be weeks. It's more like days rather than weeks, the way things have been going. As I said, it really hurts me to have to tell you this. But I thought it was important for me to say that
Yes.
so that you will be able to make plans for the remaining time you have left.
Yes, doctor. That's very important. Poor Shilpa wanted to do the best for her, but it was not always possible.
A few months back, I was talking to Shilpa, and Shilpa was telling me how proud she was to have a mother like you.
Really?
And she loves you so dearly. She knows what all sacrifices you made as a single parent to bring her up. She loves you dearly. And I think you have more than enough reason to be proud of yourself about what you did, what you achieved.
Thank you for saying that. I like to see Shilpa again, but while she's pregnant, I don't want to upset her. She'll be so sad seeing me like this.
She will be Shalini, she will be sad, she will cry, but it's very important for her to have the privilege of seeing you and to be able to do things for you. See, she she needs to feel that she could help you. She could look after you when you needed her. Because if you deprive her that chance, she will always feel guilty about it. She will always feel sad about it.
Maybe. Then I really don't want to be a burden on them. Already, I can't go to the bathroom. I don't want to eat. My poor brother keeps telling me to eat, eat. I can't.
I'll talk to Arjun and his wife, both of them, and explain why your need for food and water are coming down now. I'll explain that it's very important that you take in only what you need, otherwise, it can add to your suffering. I'll explain that. I'll look after that, Shalini.
And my poor sister in law, me not able to go to the bathroom. So much work for her. I don't want to trouble them all like this.
Yeah, Shalini, there are several things that we could do about your bladder. Somebody could clean up after you, or you could even have a catheter. In which case, the urine will drain into the bag, you know that.
Yeah, I had it once before. So I think that it'll make it easier.
If you prefer it that way, we can do that, Shalini. What else is bothering you, Shalini? Is there any unfinished business? Any something that you would like to do?
Lots of things I've done after knowing about this cancer. I've been saying my prayers. Whatever happens, it's all in God's hands. But maybe there are just one or two small things. Sounds a bit silly. Is it very strange if I write a letter for Shilpa's baby to read when the baby grows up? I'm not going to see the baby, no?
I think it's going to be very precious for three people if you will do that. One is Shilpa's baby, and it would be very important for Shilpa to know that you did it for the baby. And it will be important to you too.
Thank you, doctor. Doctor, you see so many patients like me. What will happen in the end?
Actually, you will need less and less of food and water. You will feel more sleepy. And then if your breathing becomes worse at all, we'll help with that. It is possible that there will be some rattling noise in your throat.
Oh, my uncle had that. That's horrible.
It will not hurt you, but it may bother the others. So we'll give some medication so that doesn't happen. Your secretions will get dried up and you won't have that. And we'll keep checking upon you to see if you are in any discomfort whatsoever. I think you are going to be able to say your goodbyes and have some time with your child. And we'll try to make the time as easy and comfortable for you as possible.
Yes. Thank you so much, doctor. At this difficult time, for you to come.
I'm glad, Shalini, honestly. It has been a privilege knowing you. Such a wonderful person like you. And you have enriched my life too.
Really?
Honestly. You are a wonderful person. You are something very, very special.
Thank you, doctor.
I'll visit again, Shalini. In the meantime, I'll talk to Arjun and his wife and we'll see what else needs to be done.
Thank you, Shweta. So, what was happening here? This is one of the home visits after several series of home visits, and this is towards end of life. The patient is totally declined now. Not much time left. And what did you notice? What was the feeling here? What was your observation, general observation about what was happening?
The doctor who attend the patient is trying to comfort her. I mean, that she is in the last days, and so he ensured that her death will be the peaceful. So I think as a palliative care doctor, he's doing his job. So that will be nice for the patient. So to know that she's not going to suffer, and people around her also like her. So that is what I could understand.
Yes, doctor, absolutely. So here, one few things which you made some point, that one, the having an open conversation, very open, honest conversation, and preparing the patient. Number one. Number two, doctor doing the conversation, and maybe he did a very good job. Actually, this is a professor, and we consider him as father of palliative medicine in our country. His name is Dr. Rajgopal, and the patient is actually professor of palliative medicine in CMC Vellore, actually herself. It's like kind of, it's just enacted, just a play, but in real life also, do you think it's doable? Do you think we can have this kind of conversation with our patients when we know that a patient is declining, not doing well?
Yeah, when it is an old patient, it is okay, but in a young patient, it is very hard. I mean, they are not in a position to accept that.
No, that's a different issue. But do you think it's needed or not?
Needed,
young or old? Needed. Okay, let's agree on that. Second thing is then how to do it. Like even today, with all kind of training, every patient I talk to, I'm not comfortable. That's a different issue. Like our own discomfort, which comes with that. When you talk about dying, it brings a lot of anxiety to us also. Like doing this tough job, and then this task of making the patient accept that the patient is dying. It's a tough job, but it's needed. Let's accept that. Yeah, and that is what he was trying at doing there. So I totally agree with you. Yeah. Any other comments? Ensuring comfort. Someone is saying, Dr. Kandipan says, you're trying to, yes, they discuss a lot around how to make the patient comfortable about her suffering. She didn't want secretions to happen. She didn't want to be the burden on the family. So there was a nice conversation around he nicely elicited her concerns, and he was trying to address those concerns one by one. So making sure that her suffering is minimized the best way possible. So I see very strong statement shared by Dr. Biju, which I totally agree with, that the only way to have a good death is to have a good life till the last moment of our life. And that is a palliative end of life care promise. Absolutely. I'm not saying 100% we can take away suffering, but we can still we never say nothing more can be done. There's always something we can do to help these patients. So that was something which I think that can be one take home message. We can still help those patients and their family. And also, I think if you notice how he very nicely brought, often this end of life, the family gets disintegrated. Like there's a lot of disjoint family become very dysfunctional because there's too much of stress. And how this sometimes we as a palliative care physician bring the family members together. Often there's a misunderstanding, miscommunication, and we try to bring all those things together so that they're all together in the end of life. Yeah. I think we need last few minutes with Dr. Jonathan. So there are no more comments or any more comments, which I welcome. Dr. Jonathan, you have to say something. Want to say something on Dr. Suren before we hand over to you? Yeah.
Well, that's great, Gayatri. Hello, everyone. Anybody else have any other questions or comments to end that part of the session? I think it's just a good example of how therapeutic communication can be for patients and families. And often we, obviously, as physicians, think a lot about medications and disease management and those types of things, which is incredibly important. But you can see in these moments where people are dealing with big anxieties or questions about the future that communication and just providing knowledge and reassurance about the future can be quite therapeutic. So that's a good reminder. I just wanted to touch base at the end of today's session just to kind of let people know what the plans are moving forward, because we're getting towards the end of our scheduled didactic sessions. I think next week is the last one that's scheduled. Following that, we're planning to have a session the week after on September 15th. And we really want to include people that have been attending courses or the sessions regularly. So as we talked about, I think at the beginning of the course, that attendance is very important. And so we'll be looking at people that have attended more than 80% of the sessions. And you'll be getting an email to invite you to that session on September 15th, where we'll talk a little bit more about making a plan and a schedule for moving forward with ongoing case discussions and mentoring over the coming months. And I think we'll initially try to start with some case discussions of patients that the current palliative care teams in Sri Lanka are seeing. So they're operating in Vavuniya and Talipale area. And then hopefully as we go, you all can start to contribute some of your own clinical experiences that have been particularly challenging. And we can talk about them as a group and maybe how best to support those cases. But we wanted to have some time on the 15th just to talk as a group of participants about the best way to organize it, because we realize that all of you are under an incredible amount of stress right now in terms of managing COVID patients and very heavy workload from that. And so we want to try to do it in a way that's practical with your schedules. So For those that haven't been able to attend these sessions for various reasons, I completely understand that there's been a lot happening. If you're still wanting to, participate in the course moving forward, that's great. And there's the opportunity to view the sessions online with the links that Vanila's provided for you. And then just a couple of questions to answer to kind of indicate that you've read or watched the session and learned something from it. And then you can forward those to Vanilla, and then your attendance can be recorded for those sessions. And as I say, we've kind of set it as needing to attend at least 80% of these didactic sessions, just so that there's a sense that people have had some exposure to the curriculum. We're also going to, for each session, we've compiled a few questions from the faculty, and we'll compile those all into one document to send out to everybody that's carrying on, just as a bit of a review exercise. Hopefully that can be sent out in the next couple of weeks as well. And then we'll get you to return those to us. So that's kind of the plan for the next phase of things. So anything else to add, Surin?
Sir, I just have a doubt. On September 8th, that is next week, we have like one last session on setting up of palliative care. So after that, like, are we going to tell the participants like how the case discussions are going to be and how they're going to present from September 15th onwards?
Why don't we have the session on the discussion with everybody on the 15th, and then we can plan from moving there. We'll just have one session next week.
Sure. And I just have a small doubt, sir. Dr. Suren, sir, I think last time when we did this opioid availability session with Dr. Nandini Walat, unfortunately, due to some personal crisis, we could not do a small part on opioid availability in Sri Lanka by you, which was like your this thing. So can we also just try to finish that, sir, so that that small thing is pending from the previous week, so that it will make complete.
All right. So that you want to do it, Vinila, that coming week or week after that?
Coming week, sir, so that we can finish off the entire didactic by September 8th, sir.
Okay.
Thank you, sir. Thank you so much. Is that all right, Dr. Jonathan?
That sounds great. Yeah.
Is it okay, ma'am? Because like we just missed that part of it.
Vanilla, we have the setting up of palliative care next week,
yes.
The last session. We can have including the opioid availability built into that.
Yes, the same thing, ma'am. Suggested. Yes.
Yeah.
Thank you.
In that discussion, I will try to say present, or maybe I can show a couple of slides, maybe not. Yeah. But otherwise, then there are circular, that national circular is available, that also I can share. So.
Great.
Thank you so much.
Yes,
sir. Please, sir.
I've got one more meeting to attend to.
Yeah.
So
thanks,
may I leave?
Thank you, sir. Thank you very much, sir.
I think we'll seek your help again in the case-based discussions again to help us to moderate the discussion as external expert. We'll be inviting you again.
Thank you. Thank you.
Thank you.
Thank you so much, Dr. Biju. For you. Yeah.
Thank you. Good night, everybody.
Thank you, sir. So I have shared the feedback link in the chat box, requesting all the participants to please kindly share your feedback and using the link. This is very, very important for us. And I think we'll be seeing you all on September 8th, next Wednesday at 7 p.m. So anything you want to add, Jonathan, sir, or else they can give the feedback and we can close the session for today, this evening.
Yeah, no, I think that's good for this evening.
Thank you. Thank you so much, Gayatri ma'am, and thank you, Suren sir and Dr. Jonathan for joining us this. And thank you so much, Shweta, for helping us to play the video. Requesting all the participants to kindly please share your feedback. Thank you once again and good evening.
Yeah, thank you all. Thank you. And Jonathan, have a good morning. Have a nice
Okay.
day.
Thank you. Good night.
Good night.